All of us who are in pediatric surgical practice come across with neural tube defects and hydrocephalus. How we are managing? It is said that hydrocephalus shunt is the gold standard, but still, even if you go to neurosurgery books, you'll find the best shunt is no shunt. Why? Once you put a shunt, it will remain lifelong and patient will have complications lifelong. Endoscopic third ventriculostomy is the only other option which provides no shunt to patient. We have seen this picture in our OPD. Whenever such kind of patient comes, just the consultant will ask, who was there in this case? I was at conference, who operated this? How do you operate such kind of hydrocephalus as shunt comes? There are a lot of other ways the shunt comes out. These are few common places. This is one of the cases. Recently we performed shunt. Patient came in with multiple seizures. We did a CT. Patient has subdural hematoma. Patient was taken in neurosurgery consultation. They told no, shunt is not properly placed. We put a EVD and then we'll put a redo shunt. So they did a EVD drainage, and after EVD patient deteriorated. Then a CT scan was done and patient developed multiple EDH also. So they told the problem was not because of shunt. Patient is having some kind of bleeding diastasis or coagulopathy. So you can have such kind of patient in which complication of shunt management can lead to severe complication like SDH and EDH, and ultimately the patient succumb to these complications. Endoscopic third ventriculostomy is coming in a big way. We have started doing it in our center in 2016. Now other centers also started doing this. There can be perioperative complications, post-operative complications, and shunt might not function at all. So whenever I have interaction, people do ask me whether it is worth to do. I will try to highlight with this presentation when to do ETV. If you ask when you're trying to start ETV, just one indication is there, that is obstructive hydrocephalus. Other people who are doing ETV, like neurosurgeons, have expanded its indication to cases like Arnold-Chiari type 2 malformation patient with meningomyelocele, and they have shown better outcome in patients with having ETV with shunt. Again, the indication have increased to patients with pediatric shunt failure. Shunt was there, shunt failed, they did a ETV, and then patient became shunt free. Again, literature is there. So, when to do? For us, to start with obstructive hydrocephalus. Other indications can come with time. Coming to how to do. How to do is a very pertinent question. How to do a good ETV, how to start, and good case selection is very important. Suppose you do first case and you have all sorts of complications which ETV can have, you will not be dare enough to do the second case. So favorable indications I have already touched upon. Like this patient with obstructive hydrocephalus, the first and second is communicating hydrocephalus. This is again a favorable indication, but you have to have an MRI which shows that floor of the third ventricle is bulging and anteriorly and inferiorly. These kind of patients will have much better outcome with ETV. Age. Lot of people ask when to do hydrocephalus, at what age. Lot of data is there which suggests more than 6 months we'll get good results. Good results in the form that success rate is around 60 to 70%. Even we have done in age less than 6 months, we have found good results in few cases and not so good in other cases. So if you want to start, select a patient which is usually more than 6 months of age. Then again, favorable anatomy. When you plan to start ETV, go to MRI, get it checked. See, I have mentioned the thickness of the cortex is 2 centimeter. Marking is there on ventriculoscope. You have to go there 2 centimeter. After that, you must think that you are going to hit the ventricles. Similarly, you must measure the size of the foramen of Monro. Dilatation of foramen of Monro, splitting of foramen of Monro, those things cannot be done in the initial part of learning curve. We have not tried to do that. We are selecting the cases. In this patient is 1.37 centimeter. Our scope is maximum 7 to 8 millimeter in diameter, so we can easily negotiate. So again, coming to the favorable anatomy, this is the favorable anatomy. When you enter in the ventricle, you see beautiful thalamus striate vein coming from the right side, in case of right, septal vein from the midline, and choroid plexus. This is a landmark where you can enter the foramen of Monro nicely. Then you can identify beautiful anatomy as mammillary bodies and basilar artery pulsation just above the mammillary artery and optic chiasma and infundibulum above. What is unfavorable anatomy? This is one of our cases. When we went inside, there are two openings. Thalamus striate vein is not seen, septal vein is not seen. The second opening which is seen, it is not a foramen of Monro. The smaller opening is aqueduct. And the bigger opening is now we are going into the fourth ventricle. And when we came back and we tried to identify the important structures as in ETV, we are again going the foramen of Monro, no mammillary body is seen, no basilar artery pulsation is seen, infundibulum is not seen. So these type of anatomy or cases should not be touched upon initially. We abandoned this patient and proceeded with VP shunt. Technique, how to access. I will touch it upon a complete video. The access point is classically Cocker's point, 2 centimeter above and lateral to midline. In midline, there is sagittal sinus, we need to avoid it. And in the coronal suture, there is motor cortex, so we need to go to 1 to 2 centimeter above it. The trajectory, I will touch upon in the video. The technique, we open the floor of the third ventricle and form a space for CSF in the prepontine space. The CSF will follow the new path. This is a video of endoscopic third ventriculostomy stepwise. This case we did at AIIMS Jodhpur recently, and I'm thankful to the team for such a wonderful edited video. The patient is placed in such that external canthus and eye are in perpendicular to the plane. We are opening the dura here with the help of bipolar, which avoids bleeding at this point. Bleeding from inside we can avoid. But bleeding from outside is also very important, because once you are going inside the ventricle and there is bleeding, it will keep hampering your vision and you will not be able to proceed. This is the way we puncture. We use VP shunt ventriculostomy needle. Now we are inside the ventricle. We can nicely see again anatomy, thalamus striate vein, septal vein in the midline, foramen of Monro, nicely delineated. The floor of the third ventricle can be visualized. Lower down we can see the aqueduct. We need not to go there. Again, this is the mammillary bodies and pulsating basilar artery in the floor of the third ventricle. Where we have to puncture is a very important question, because everybody is fearful of artery bleeding from basilar artery. Never focus for the floor towards the base, towards the mammillary artery. We have to go towards the infundibulum. Ideal place is the center, where I have marked it as a target. In case you feel basilar artery little higher up, you can even feel the bone, that is dorsum sellae, and come down and can start puncture. This forceps, decay forceps was told, is a very nice instrument which is available in the stores. It can help you to open it gradually. It is serration outside, so it catches the floor and it does not let it slips. After you form an opening, you can pass a Fogarty catheter. Fogarty catheter, there is working channel of 5 French, 3 French, depending upon what kind of scope you are using. While inflating Fogarty, you must not inflate in the ventricle, because there is must not inflate behind because there is basilar artery. You must inflate it in the ventricle itself. You must see half of the balloon at least. And once you do it, there is a good opening. You enter, you can see nice, beautiful basilar artery, and the procedure is complete. Touching upon Lilliquet's membrane, what is this? This is another membrane which you find when you open tuber cinerarium, that is floor of the third ventricle. Opening this has lot of prognostic value in rate, like increasing the rate of successful ETV. This is one of the cases in which we found Lilliquet's membrane. We opened with Fogarty. We made an opening in the floor. We opened with Fogarty. Then we went inside. We should ideally see beautiful basilar artery and pulsating branches, but we could see this kind of membrane. We could not see any basilar artery. So again, that forceps, decay forceps, is very helpful. I personally am not very confident in poking anything inside near the basilar artery. So what I do, I catch a little bit and then try to tease it off, and with gradual movements, We all are doing very big surgeries in very small spaces, so it is not a big deal for us. After a while, you will find all the membrane is gone. You can see the basilar artery and its branches nicely. This completes the procedure. And this will increase your success rate initially, but you have to be very careful during this step. This again, choroid plexus ablation, I have taken it. People are claiming that once they do ETV with choroid plexus ablation, especially in cases with meningomyelocele, it increases the rate of successful ETV. Again, a bipolar can be used, and whatever choroid plexus you can see in the third ventricle, in the lateral ventricle, anterior horn, lateral horn, you can burn it with a bipolar. Data is there which suggests that once you combine choroid plexus ablation with ETV in some cases, the outcome will improve. Overall complications can be there. The most dreaded complication is bleed. But for all of us, the most common complication which we find is CSF leak. Most of these patients will have a fever in post-operative period, for which we prescribe antibiotics and all. So bleeding remains the main hurdle which hinders us to take this procedure. What we do when there is bleeding? Bleeding from basilar artery, we have been lucky enough and careful enough not to puncture the basilar artery. Bleeding can come from outside, which we need to coagulate or use bipolar before going in, or bleeding can come from inside in case of thick floor of the third ventricle. So if there is bleeding, what we will do? This is one of the procedures, videos which we can see. We entered, we did the procedure, we completed the procedure, we saw the basal artery, suddenly there was blood which was coming out. We might have touched upon some small vessels, we could not do anything. We just kept our scope there. We used 37-degree ringer lactate, and there are two channels in this scope. One channel is always open and which keeps irrigating. You have to have patience and you have to just wait for 3 to 5 minutes. Gradually the whole of the blood will definitely get clear by this way. Now you can see. Even if you cannot get control of the bleeding in this way, what you can do, you can put a Fogarty in the opening and inflate the Fogarty 3 to 5 ml and just wait there. The bleeding will stop spontaneously. We have been lucky enough or careful enough to manage bleeding with such cases in all the cases. ETV is very good. I have told the positive points. What complications I told you? Complications like this, a child comes, people called it, we have seen patient becoming, and Gangaji coming from Shankarji's head like this. So we have also our share of complications. Patient come with such kind of leak. Waiting with Diamox 2 to 3 weeks helps us to open the cistern and get a good channel. The leak stops spontaneously. Suppose it does not stop, what options we have? We have always the option of putting a shunt in these patients. We can definitely go back when CSF culture is sterile, we can put a shunt, and lucky enough again, we have been able to manage most of the leak of the cases without any shunt. 3-4 cases across all the consultant which are doing need shunting for control of such kind of CSF leak coming from the side of ETV. We use, personally I use a neuroendoscope which is handheld, and this external diameter is around 4 mm. That is OE handheld neuroendoscope. Maybe that is a reason for which we do not get lot of CSF leak, because our patients do not have lot of thick cortex which can prevent the leak, and making a larger hole can propensate for leak. We started a endoscopic third ventriculostomy in year 2016. Till February, we operated all, cumulative all the cases across all the consultants, around 124 patients we operated. I have already mentioned we did not have any basilar artery injury till now, which is the most detrimental. Others, what happens? It's not functioning. Redo ETV we have done. If not functioning, shunt is always there. These patients, shunt can be placed. So again, I will just emphasize, even if you do 100 cases of ETV and suppose 90 are failing and 10 patients are shunt free, just remember, no shunt is the best shunt. Even if you are making 10 patients shunt free, it will give those patients complete life without any complication. Second most important thing, with kind of devices which are there and vision system, it's very difficult to have a catastrophic bleeding, and which can be easily managed, though there is learning curve, but case selection at the initiation of the procedure is very important. In fact, it's the most important thing. MRI, anatomy intraoperatively, and careful while perforating the membrane, you can avoid any kind of catastrophic bleeding. We must take this procedure because even our trained residents who are passing out from BHU who are doing ETV, when they are going outside, they are not getting ETV cases because people outside are not sensitive enough to hand over the cases because it is thought that it is a procedure of neurosurgeons. So our association, ma'am, gave this opportunity in national conference. I think we should make it a habit, and INIs, government institute should take up this procedure so that we can make this. Suppose a shunt comes out, but it perforates rectum. Every time neurosurgeons refer to it. So if we are able to manage most of the complications of a procedure, we are liable or eligible to do it rather than somebody who is just managing one of the complications. And to end, I will like to quote Sir Isaac Newton. If I have seen further, it is by the standing on the shoulder of giants. Some of why you people might recognize Professor A.N. Gangopadhyay and Professor Saroj Chudamani Gopal. And above is the Professor Sujo Oi. He was the president of Neuroendoscopic Society World Congress. He visited IMS BHU in 2008, and we got first neuroendoscopic conference of India at BHU Pediatric Surgery. Fortunately and unfortunately, the procedure was not taken up for 10 years down the line, but still we were the first one to take this procedure. And this is a high time. We should train our residents and we should take this procedure. Thank you very much. Any questions?
Excellent talk by you, Vaibhav. And one query I would like to ask you, how you know pre-operative that this patient will benefited by that third ventriculostomy or state pay, I will go for the ventriculoperitoneal shunt?
Yes, a very good question, sir. To start with, we must have case selection in the form that these patients are going to benefit. So we'll select these cases. If they are not going to benefit, we'll go for shunt. Just to have a continuous deal with of going with a new procedure. How to select? Sir, obstructive hydrocephalus usually responds to ETV. Even there are stroke volume measurement softwares in MRI, routine MRI, 1.5 Tesla MRI, where you can measure the stroke volume, which suggests flow across the ventricles, which you can document pre-operatively. It is more than 25 different, studied co-different. The patient is going to benefit from the procedure. Second, what I have told, obstructive hydrocephalus, sometimes it's very, not very common to find. Even in non-communicating hydrocephalus with good bulge of the floor of the third ventricle, anterior and inferiorly, those patients are going to benefit. We must consult our MRI colleagues, radio imaging colleagues, and we should select these patients. Other important things, as I have already told, length of the foramen of Monro should be adequate so that we can negotiate our scope. And once we are inside, basilar artery anatomy. If these 4 or 5 things we keep in check up to the operating table, we will be able to select out most of the cases which will not respond to ETV, and we'll be doing ETV only those cases which will respond, sir. This is the way we have started it doing. We kept it doing for 4, 5, 6 years down the line. Now we are increasing. Even we are doing in a 3-month-old child with intraventricular hemorrhage. We are just washing away everything and just making a hole. Just making a hole will not make patient hydrocephalus will go, but again I will say in some cases it can be effective.
Very good. But one thing I would like to know, pre-operative, can you assess the turbidity or the something of the CSF by which you can defer the surgery? Because recently we have opened 2-3 cases. What I found after putting the scope in, there was a turbid CSF. So ultimately I just shifted to shunt operation. But can be possible pre-operative to judge that this patient require shunt surgery or some diversion before thinking for third ventriculostomy.
Yes, sir, definitely. MRI again, sir. In such cases, in turbid, MRI will definitely show, or even a transcranial ultrasound will show, like in cases where there is infection and abscess, you can find that CSF is not that conducive, or you can have multiple septation inside the ventricle itself, which are result of long-standing or recurrent, what you called meningitis. So these patients you can select out very easily. And even if on a turntable you are finding that CSF is not conducive, it is very well that you went for shunt itself because it did not do any harm to the patient, sir.
Okay, thank you. Any other query from the floor, please?
Yeah, one.
Any other query? I like to answer.
Vaibhav, one point.
Yes, sir. Yes, sir.
The way you presented it, it seems that everyone who has been trained under you or watched this kind of sessions must be able to go and do these things individually. I understand that the Coker point you have mentioned, Coker's point that you
Yes,
have
sir.
mentioned is the key to the right way of doing it, and as well as the equipment and the angulation. And how do you identify the coronal sulcus?
Yes,
Plane.
see, that is hitting the ventricle is the, hitting the Arjun's eye, like whatever, Arjun hit the eye of the fish. That is very important. You have to have important 1 to 2 centimeter above, away from the midline towards the right. We choose right because left is in most cases the dominant hemisphere, so we should not go to the left. Again, most surgeons are right-handed. So avoiding midline, you will avoid the sagittal sinus. We can identify by sagittal suture. God has already given a very important landmark. Then you can follow the boundaries of the frontal, what do you call, foramen. And then you can see the sagittal sutures. And you have to be 1 to 2 centimeter away from the sagittal suture because motor area can be there over the sagittal suture 1 centimeter. So if you are avoiding those 2 points, 1 to 2 centimeter lateral and 1 to 2 centimeter above from the coronal sulcus, then you get your point where you have to enter. Second thing, sir told, in what angle you need to enter. Then patient positioning plays a role. Patient has to be placed in neck slightly flexed so that the tragus and external canthus should lie perpendicular to the midline, and you should focus your endoscope perpendicular to that plane. So if my patient is lying like this and I am finding the plane joining the external canthus and the tragus like this, at that point I will try to perpendicular puncture this plane. This will help me not to go either posteriorly or anteriorly or to the left side. Sometimes it happen in hydrocephalus, huge head size is there, and when we enter, it is completely dark. It is called the dark ventricle syndrome. Because there is a specific focal length, you keep on going in that trajectory, you will find the foramen of Monro. Sometimes what happens, you go to opposite side, that is left side. In that, you have a very important landmark. The thalamostriate vein will come from the left side. You must identify your anatomical landmark, foramen of Monro formed by thalamostriate vein from the right side and septal vein from the midline. So if these 2-3 points, yes sir, any pediatric surgeon who is practicing laparoscopy or cystoscopy or endoscopy can do this procedure, but we have to be take little bit of care not to get over enthusiastic with initial cases. Anybody can take this. The procedure takes 15 minutes maximum. No suture material, no extra cost to the patient. The anesthesia time of your OT will not be wasted. In and out, whole time is around 30 to 45 minutes as of a cystoscopy. So definitely anybody can do it, even in busy setups.
The ordinary laparoscopes and those things we use, those are not useful.
What, sir?
The laparoscopes and other scopes we use routinely in our OT, those are not useful.
Sir, again, the better armamentarium you have, the better it is. I will not suggest to, maybe our seniors, some people have done it. Dashmi sir is sitting here, he has done it with cystoscope, but we have not done it. And the vision, the quality, and the whatever he told, 6-degree scope is there. So as soon as some instrument is inside, we have very little margin of error. We know that as a pediatric surgeon, we always have lesser margin of error. but still it is always advisable to go with these scope rather than to venture with, because what will happen, we might land in some kind of complication or failure of the procedure, which will not let us to proceed with this procedure in future, sir. So it is very important to have proper armamentarium. The forceps which is there, that is it has prevented bleeding in all of my cases. It is so beautiful forceps that it will never traumatize any vessel. It helps to open the floor very nicely, and that forceps has maybe prevented bleeding or catastrophic bleeding in 120 cases which we have performed over 10 years. So I think armamentarium is very important.
Questions from the floor, please.
Nice talk, Vaibhav. We do see some pediatric neurosurgeons being aggressive and extending the indications to post-hemorrhagic hydrocephalus in preterm babies. Your thoughts on your experience on that? And if it can be done, how early can we do that to reduce the chances of permanent hydrocephalus and damage?
Sir, as smaller children are being saved in an ICU, we are also seeing upsurge in the patient neonates, 1.5 kg, 1.2 kg with intraventricular hemorrhage. And now we are coordinating with our nursery. One case I have experienced, I went inside. I just washed the ventricle, kept washing it for till whole of the blood was away. Then ventricles were looking very nice and clean. We just did that. Post-operatively, patient was supposed to do well, maybe it did well. So even our nursery colleagues are now pushing us to do such kind of cases. I don't know whether it will be beneficial in what kind of cases. We don't have a lot of experience in that, but definitely it can be done. And there is a lot of literature from the Western countries which suggests that draining out the blood in earlier period will make you shunt free again, which is the whole purpose of ETV. Rather than waiting the blood to block the passage, lead the patient into a hydrocephalus, you just wash the blood beforehand. So it has a therapeutic potential. But again, you have to be very careful. We keep irrigating these patients with the ringer lactate. Hypothermia, very small children, the size will become again smaller. Even a 6 millimeter neuroendoscope will seem little larger for such small children of around 1.2 kg, because these patients will invariably be less than 1.5 to 2 kg, sir. So yes, it is feasible. I have done it, and there is a lot of literature in Western countries which suggests it should be done. It can be done.
But in PHHC, once you have done that, do you need to go in and give repeated washes, or do you keep the seri-drain type of shunts where you can still use it to aspirate if the hydrocephalus increases?
Sir, what we did, patient was, we went inside, we washed whole of the blood, and then we came out, we closed everything. People are putting EVD kind of devices which they can use repeatedly to flush it out and take it out. Again, said all these things. I have shown one patient in the initial MRI, CT scan. Patient was on shunt with SDH. EVD was placed to tide over the crisis, went into EDH. So all these devices put from outside externally have their bag and baggage with them. So we have to be careful, as we don't have very much experience, and to find such kind of device for such a small kid in our setup, it's not, we have not found it, sir. And neurosurgeons are not doing it, sir. And so most of the neurosurgeons will say, or the data will say, that it is not effective in smaller children. Hydrocephalus is a congenital anomaly. It will come in children, sir.
Thank you.
Thank you, Professor Vaibhav, for the wonderful talk. I would like to say that being mentored under Professor Vaibhav in ETV itself, I have done this for last 2 years and would like to say this is a very good procedure and we have seen very good results. International literature is documenting it, that the success is around 75%, but we have had a better results at our center. And if you have a better mentorship, you can take it up. And even the young surgeons, even our residents are doing the procedure at the moment. So I would like to say and request IAPS, just I would like to request IAPS also to just promote this procedure because it's a very handy procedure and these obstructive hydrocephalus do get going door to door between pediatric surgeons and neurosurgeons, when we can do this procedure with efficacy and in a very short span of time. So we should take this up. So thank you so much, sir, for bringing this up. And the talk was very good, and I think we should continue with the workshop.
Thank you. What will be there in workshop? There are two stations which STARS is having. Two are ETV stations in which they have got model of papaya, where you will form a puncture like endoscopic puncture, what we do in ETV, and you will be able to manipulate what kind of manipulation we do. Two other stations are for what you saw, the exostome, I think, whatever it is there. So ETV station, we can have whatever I'm not seeing a lot of people are there. Whosoever is interested can join. Dr. Sunil ji has been conducting this kind of workshops for past 15 years, so he is very well versed. And he will answer a lot of queries regarding the instrumentation. Even if you are having neuroendoscopy at your place, you must visit and discuss with him regarding technicalities. Thank you, ma'am. Thank you. Especially, I like to take this opportunity to thank ma'am to provide such a place or podium for me to share my experience and our experience as a whole. Thank you very much, sir. Thank you very much, ma'am. Thank you. Thank you.